Okay, today we're going to talk a little bit about what it actually encompasses, what does a physical therapy evaluation look like? A lot of people don't know. They've never been to physical therapy and they're really sure what to expect. And sometimes that's a little unnerving. So I figured today I'd take a few moments just to talk about us doing a physical therapy evaluation. We're going to do it for the back actually from Matt's back. Matt works here. He's actually a promising orthopedic surgeon. He's starting and observing a little bit here and getting some information. And he's going to be our subject. We're going to just kind of run through what we do when someone first gets here. So anyway, one of the first things we do, Kathy comes in, talks to him, we get all the paperwork done, and we kind of get a sense of what's going on. You're going to provide us information on medications, any kind of tests, blood work, maybe a recent physical, kind of giving us an overview. Also some information on there will tell us about when it started. That's really important in any kind of condition. What things are making it better, what things are making it worse. Is it getting better since it occurred? Is it getting worse? And kind of how it acts, okay? And what we get that information is from you. So we're talking to Matt about these different particulars. We really want to understand how it acts because Matt knows more than anyone else how his back pain feels, what makes him feel better, what makes him feel worse. Is he nervous about it getting worse? All those things are very important. In fact, we give our people here a little survey that you fill out. It hurts when I'm sitting, it hurts when I'm standing. We kind of want to know how it acts, when it bothers them. And it also tells us, for the evaluation, if someone's very sensitive, because they say, gosh, my back is really sensitive, be really careful with me. We also know to be a little more careful with Matt when we're evaluating so we don't overdo it and flare his condition, which would be the worst thing we could do. So anyway, but we understand. So Matt's, your history and what you tell the therapist or doctor, even the orthopedic surgeons, important to tell them how it acts and be a good historian, I call it, like really have a good understanding of things that bother it. So people want x-rays, they want MRIs, they want all these special tests sometimes for lower back pain, sciatica, and oftentimes that's not always necessary, okay, in the early stages, depending on a few things. But those are an important part of the clinical picture at the right time. If Matt is telling me I'm getting weaker and weaker, I'm starting to lose control of my feet, he's not seeing me. He's going to the ER really quickly or an orthopedist, and we're making sure we're doing some tests to make sure that weakness doesn't get worse. Other things that you may not come to me right away, let's say for a lower back problem, is horrific night pain to the point where it may be a tumor, an infection, something more serious, something that we got to tell Matt to go right away and not to, Another thing we'll talk about if there's a loss in bowel and bladder symptom or ability to hold back urine, like you're unable to control your urine, you're unable to expel a bowel movement, and it happens very quickly, especially after a trauma, a fall, something very significant. Those are some of the cases that you really want to get to see a doctor immediately, and don't go to me, okay? Because I'm going to tell you to go out the door. So those are some of the things that I consider red flags. There's other red flags out there for lower back and sciatica that we'll talk about, but that's a little bit more comprehensive. But that's some of the big things. Progressive weakness. All of a sudden I'm getting weak really fast. I don't mean like I'm a little weak because I'm tired because I worked in the garden. I mean like all of a sudden you can't raise your arm, you can't raise your leg, big things like that. So those are some of the things. So in our evaluation, we do a Mckenzie Evaluation here. We'll take someone through the questionnaires, some of the things we talked about. We're going to first know, how old are they? There's certain conditions that occur at certain ages that we get more concerned about. So if someone that's a little older, it might be osteoporotic. Obviously, Matt's not going to be osteoporotic or highly unlikely unless he has another condition. We want to be careful with them. We can't do certain things when we evaluate them. Date of birth, that's why date of birth is important. We want to know if they saw someone else beforehand. Did they get treatment from a chiropractor beforehand? Another doctor, maybe they're coming to us from the orthopedist, maybe they haven't seen an orthopedist first. Who's seen them first? And sometimes when they see another therapist and they come to me, or a chiropractor, I learn a lot from it. What I learn is maybe what's not going to work for them, and maybe a little bit about how their course of treatment, what things they liked, what things they didn't like, what things they didn't do well with. That also educates me, and it's actually easier for me to see you as a second person in or practitioner. So I learn a lot by that, and I can only learn that to talking to Matt. So that's the most important thing. What things do you like to do? So what do you like to do? What's some things like recreational things you like to do?
I like to ride quads, for example.
Ride quads, okay. So maybe, ride quads, that's something that he wants to get back to. We have to be aware of, we say go ahead and do anything. Maybe we want to be careful he's doing quads. He might, jumping around, rolling. Maybe we want to be careful we know exactly what he wants to go back to. So quad thing, okay. Anything else? Do you work out in gym?
Yeah, I like to go to the gym, and I like to swim.
Swim,
also,
okay.
Yeah.
So we want to know what activities, what do the swim bother you at all, and we want to keep them as active as we can, especially with lower back conditions. We want to modify it as much as we can. We want to let him be as freedom. We want to keep him moving as much as we can, as long as we don't make his condition worse. So we think we can allow him, quads probably not, but if we can get him swimming and keep him going, I want my patients to be as active as they can so they don't get deconditioned, they don't lose strength as we're trying to help them with their back. So he likes to lift, powerlift. I'll go through things that, maybe he's doing something in the gym he doesn't realize. Like every time I do a deadlift, I have a problem. Good, that's something we're going to look at after the evaluation, make sure he's doing it right. Maybe there's things he doesn't realize he's doing that might be affecting it, okay? So we talk about mechanical stresses. We'll talk about a scale like 1 to 10, where is his pain related? Now, the 1 to 10 scale, 10 is you go into the emergency room, you feel like your leg's cut off, or it could be cut off. 0 is no pain, and 1 is like kind of that mild pain. What Matt tells me as far as the pain scale is very good for him. Like his 2 is good, is his 2, but his 2 is different from my 2, but at least it's a starting point. So when I ask people, they hate to give a number sometimes, but I say, whatever you rate it as, it gives us a starting point, okay? Then we ask, like, what are your symptoms? Like, what are you feeling right now? Matt doesn't know what I'm gonna ask him, but what his symptoms are. He doesn't have back pain, but he may have, let's say, leg pain or foot pain. Is it gone? When did it start? Like, was there something that occurred? When you have people with, say, I give the example of osteoporosis, osteopenia, sometimes they can have a minor trauma, like take a little step off a stoop or something like that, a little jolt, they get a fracture from it. For Matt, he's a younger, healthy individual, very active, he's a weightlifter and things like that. I don't get worried about small things. I'm more worried that he fell off his quad. In those cases, when Matt tells me that, that's when it started, and it's really getting worse quickly, I may say, I don't want to do this evaluation until we do a good, at least a basic x-ray. So, not trying to take the doctor's attitudes for him, I'm just saying there's times where you definitely want some basic imaging. If there's nothing really traumatic and we've made sure that there's not a lot of bad things that have happened, red flags, then we can evaluate him first, and typically we don't need an x-ray or an MRI. Generally we just want to, but we'll ask him a few specific questions, or the orthopedist will, to say, hey, have you experienced this? Is this going on? Okay? All right, so present symptoms, how long has it been occurring? What started this? Was there a particular incident? A lot of times the lower back patients, they'll say, I was just driving home from the shore and I was in the car for a little longer, 2 or 3 hours coming back from Long Beach Island, and that's when my symptoms occurred. And that's not an uncommon scenario. It can be the CrossFit guy that's lifting 2 and increasing his weights, whatever, or the runner that went a little further than she's used to, or hiker. But sometimes it's literally just sitting. That's one of the common things with lower back problems. You'll see it was just one position too long. So it's interesting. My snowbirds, when they're coming back from Florida, they're the ones that'll say, I just had a long drive, and that's when it started. So anyway, so that's another thing. So we want to know when it started, a few things about it. We want to know where the symptoms are, especially the further symptoms. Sometimes it's just general lower back pain. Sometimes it runs down, let's say, into their feet or particular aspects of the foot. It could be burning, tingling, numbness, pain, a variety of things. But we want to know what he's experiencing right now. Certain things we can tell from, certain things he's got to tell us. And there's certain common things, but you want to let them talk about it. We want to know how you describe it. Other people, there are different ways. We also want to know what's worse and what's better. What things clearly make it worse. Matt says to me, hey, I sit for more than 10 minutes, I'm in a lot of trouble. Okay, so we know that's a starting point. If we can get him, it's also a sign when we start seeing him get better, hopefully, that he's getting, now Tom, I can sit for 30 minutes, it doesn't seem to bother me, because we've gotten it on the initial intake, we know where he started. Sometimes it's hard for the patient to tell he's improving, like, I hadn't thought about that, yeah, I can sit longer, I am getting better, or I'm getting worse, and make a change in treatment. So we want to know what things make them better. Commonly with patients with disc problems, they say, listen, I love standing, especially walking and moving, hate sitting, turning, flexing. They'll say the morning is really hard. They say, God, the morning is the worst, the first couple hours. Some people that have other type of back problems, the morning's great. It's really when they start moving that they start having trouble. So we'll ask, what's worse, what's better? We'll kind of note this down here. Is your sleep disturbed? That's one of the things we classically ask. We'll ask what kind of mattress you're on, what kind of pillow, how many pillows. We also want to know from, has this happened before? How's it acted in the past? Unfortunately, a lot of these lower back conditions, they are worse the next time you get them, unfortunately. Some people start with lower back pain, then they start developing sciatica the next episode, sometimes weakness. So we want to know what they did in the past and how it's been addressed in the past. And also concerns maybe. They're a little fearful, wow, this is the second time maybe this has occurred. So we want to know about previous episodes. We also want to know previous treatments. Does he receive chiropractor treatment, acupuncture? What has he done in the past, and what's his success been? And also we learn about Matt a little bit about his apprehensions, fears, concerns, what things kind of he was positive about by understanding how he talks about those previous treatments. And then we move down to specific questions too. Does it hurt when you cough? Blow your nose, laugh, things like that. We want to know how sensitive the condition is. It tells us a little bit about it. Sneezing. Is there any medications? I mean, he might be having a great deal of painkillers in him right now, and he may not be registering as much pain with the evaluation. We want to be aware of that. He may be taking Advil or other medications that are blunting the inflammation. So I don't know what he's taking, and also if he's taking medication and he goes, wow, I'm feeling the same, but I've gotten off all my meds, that's a sign you're getting better. You don't need medication anymore. So those were other things that we like to know about it, and also know what's in his system. Also, if Matt says, I'm starting to develop a lot of abdominal pain, I'm starting to see a little blood in my urine, maybe he's developing some bleeding from some of these medications. We want to inform him, by the way, this might be from here. We're not sure, but you might want to talk to your internist, your doctor, or orthopedist about it to make sure that's not occurring. General health, does he have other things that are going on? Has he a history of other ailments? Does he maybe have something systemic? Does he have lupus, MS? Is there other things that might be a concern for him, based not just lower back, like there's other things that make this problem a little worse. Has he had imaging? Imaging is great to have when you have it. If people come in, I look at it, I want to see what's going on, what the doctor said. More input is the better. There's a lot of MRIs and x-rays out there of people that have got bulges that don't have any symptoms. So we want to look at the MRI and respect it, but we also want to make sure we talk to the patient and also see how they move to make sure they kind of match up. I've had a lot of people that say, wow, I've got an MRI on my lower back, I got a huge disc bulge, and I said, it's on the right side. And he goes, and I say, well, where are your symptoms? We're all on the left. So we want to make sure they match. We want to see the MRI matches the clinical, which means how Matt talks about it and how Matt moves and what happens when Matt moves. Okay. So the Mckenzie Evaluation, there's a couple other things we'll talk about later on, and maybe in another video. But the next part is we're going to check his posture. We're going to have him stand up first. We want to see how he looks. So let's have you stand up, Matt, and just stand right here. We're just going to kind of look at his posture. Is he forward? Is he forward head? Matt's pretty young. He's got good upright posture. Then we're going to have him take him through a series of movements. Now the Mckenzie Evaluation is we're trying to see if there's any movement loss, and ultimately we want to see is if a position or a movement changes his symptoms. Now we're going to pretend like Matt has right thigh, lateral thigh pain, okay? All right? And he's also got lower back pain. So the pain's extending basically from here on him, down to here. If we notice when we have Matt move that pain starts moving up, that's typically a great sign. So whatever you call it, burning, tingling, the pain, starts moving up, that's a better sign for Matt to experience. If Matt starts experiencing, we're moving, we're having him, let's say, bend forward a series of times. Now the pain's going below the knee. It's going down into his foot. It's important to get the starting point. Whatever the starting point is, if it moves up, good, down, bad. All right? So the first thing we do is we have Matt kind of go forward. So let's kind of run forward and try and run your hands down around the front of your thighs, shins. That looks good. How does that feel? Great. Okay, come back up. We'll ask him, does it make it worse, better, no difference? He goes, gosh, you're killing me. Don't make me do that again. Okay, won't do it again. Let's go lean back. So we're going to place our hands on our hips. We're going to have you widen your stance a little bit. I want you to lean back as far as you can. That looks good. Good, and then stand back up. And then we're going to do a side-to-side assessment. So we're going to have Matt just move with me. Hold your hands like so. And we're going to have him side glide to this side, like that. Then side glide to the other side. And we're looking for any kind of big differences side to side. And then stand back up. If Matt is very tight, and it's hard to tell, we only have one spine. When we have shoulders, we can tell one shoulder is very different from the other. But we want to see how far he moves back. Now I've been working over 20 years now with people. I know how far the back goes, and there's measurements too we can take to see what the average motion is. But if I see he has loss of motion there, even if he has pain, I may want to look at certain motions more than others. He looked like he'd go pretty far. You got pretty good range of motion. Some of that's from the hamstrings, and some of it's from the lower back, okay? When he leans backwards, if his hips are tight a little bit, that'll affect the motion, but how far he can arch. One of the most common directions that we see movement loss is going backwards. So what we're going to have Matt do, and I'm just going to make it a little shorter, is we're going to have Matt do that same movement a series of 10 times. So let's go ahead and place our hands on our hips. We're going to lean back as far as we can. So pressure on, you got to go as far as you can, and then pressure off and we're gonna do a series of 10 times. As Matt's doing this with us, we're basically we're asking, how are the symptoms changing? Are the symptoms in his thigh right now moving up, moving down, getting worse, sometimes they don't even move. Matt says the lowest symptom right here is a 5. That's where my pain, I got a burning and a 5 right here. If it doesn't move, that's okay. If it's neutral, or actually it's less intense, it goes from a 5 to a 3, then that's good. That's actually considered a positive sign. Sometimes as I do the movement also, you'll see that the movement improves, but there's no change in the symptoms. That's considered better. I like to see the pain intensity decrease or move up. But if he just gets much better range, like significantly better, sometimes it's just a matter of Matt doing that movement for a longer period of time, and then over time he starts feeling better. So let's do a series of 10 while we're here. We're going to do 10 on it. Let's see if even Matt, Matt's got pretty good flexibility. Definitely better than me right now. So after he does about 10, we're going to have him stop, and we're going to ask him, how you feeling? What's going on? What are you, where is the pain right now? How's your movement? And I'm also checking to see how his movements are. Now, I'm just going to make a mention of this as Matt's finishing his arches, but if you also will check his strength in his legs to see if there's any neurological loss. That's something. If Matt was complaining about a lot of weakness in his legs, pain below the knee, we'll sometimes do a neurological evaluation. We'll check his reflexes with a reflex hammer. We'll check his strength. We'll check his sensation. Say, wow, sometimes say side to side, there's a difference in how it feels in the legs. We're not going to do that today, but that's one of the things we'll do if Matt talks about a lot of weakness especially. We want to know where his starting point is. So after Matt finishes this, we say, okay, how do we feel? So that's the most common movement that you'll notice seems to help people. There's other movements, sometimes, especially when people complain of problems just on one side, we'll do other types of movements. One of the movements we do for people that are having pain just on one side commonly is we'll have them do a side glide. So hands on your hips, and you'll just side glide to one side. Your trunk moves typically towards the painful side. So you do a series of 10 times. And after 10, if we get to 5 and Matt's screaming and he's saying this is killing me and it's going below his knee or it's just too intense, we'll have him stop. But typically we do about 10 and then we stop and we reassess. Like we said, of the history, when we talked to Matt at the start, we want to see where's his starting point, how's he feeling? So we want to be talking during this whole evaluation. And pain movement is very important, and it kind of guides the evaluation, so we don't do something that's going to hurt Matt. Now, the first times that I see so, and most times I'll take them through and I say, wow, we find out that this movement feels better. Sometimes I'll say, let's go ahead and just do this movement at home. It's a typical prescription I'll tell people to do is do this movement 10 times every 2 hours. Matt's like, I'm not getting good signs from this evaluation. What I may actually do is I'll have him lie on his stomach and do an evaluation of him maybe doing the arch or the bend in a non-weight bearing position on the table. But basically, as we do this, all we're trying to do is see. I'm talking about movements or positions that'll reduce over time. You start seeing an increase in motion and a reduction in pain. Okay, and that's the big thing. If it just happens here, that's exciting. What we hope to see is that over time, typically like 2 or 3 days, we see a change. Like he says, wow, I've been doing these 10 times every 2 hours. Typically like 5 sessions a day is the best. Then after 2 or 3 days of doing it, you see a trend, whether someone's actually going to improve, not improve, or improve slowly. So a fast responder, slow responder, and non-responder. But 2 or 3 days, if he's really compliant, that's when he starts seeing changes or you know something about it. If he does this movement for 3 days, he goes, Tom, I've been very good. I've stayed away from the things you told me. I didn't do any four-wheeling or quad-wheeling. I just did a little bit of swimming. I really stayed away from things that really flared my condition. And he did the exercise. Then we really evaluate and we say, okay, maybe we missed something. Or maybe he needs hands-on. He goes, Tom, it's neutral. It's not worse. Then we start doing some more hands-on. Sometimes I'll do hands-on stretching the first session you're here. And I'll show one that we'll do here on Matt's stomach. Sometimes I'll say, I'm not sure. He seems kind of like sensitive to a lot of what we're doing. What I do is I let them do the exercise on their own and say, make sure it should not make your symptoms worse. If they make it worse, you stop, you call me, and then we'll reassess you on the next time you come in. But important thing is he understands the precautions and that understanding what's good, bad, and bad pain. One of the things that scares people here is they'll go ahead, and this is a spine. Luckily Matt doesn't look like this. This is the front of Matt, and this is the back of Matt. When Matt arches back like that, oftentimes when they do the stretch at the very end, they'll notice the same pain. They go, Tom, I can feel the pain at the very end of the motion, and then when I stop, it goes away. That's good. If I'm doing it, pain at the end of the motion, oh, now it's worse. Now it's more intense in my thigh, let's say in his thigh. or now it's running down his thigh. Those are things that we want to really stay away from. So we give a little handout here. It's chapter 4 of the Treat Your Own Back Mckenzie book, and explains the movement of pain and what's good pain and what's bad pain. I don't mind if my patients have pain if it's actually a solution long term, like if they experience a little discomfort but they feel better overall. But it explains pain, movement, and location. That's really essential to understand that. A lot of people do these exercises and don't know the precautions. That's one of the things that's incredibly important for this system. It's a really systematic approach. But let's say Matt looked pretty good, but we weren't quite sure. Like the standing one was okay. Now we'll have him lie on his stomach. So I'm going to take my clipboard, get out of here. Matt, we're going to have you lie on your stomach with your head up this way. Okay. Now, since he had a lot of pain, I'm making this up, but as he had a lot of pain flexing forward, we're going to have him do a press-up. Sometimes, especially you're under 50. Matt, you're under 50, right?
Yeah.
You're under 50. Yeah, he's got a lot of orthopedics go at him, so I'm glad he's under 50. So what he's going to do is going to place his hands underneath his shoulder, like this, and he's going to press up. I like to have their legs a little wider, actually. Sorry, Matt. And we want him to push up using just his arms. So push up, Matt, so you get a little bit of arch here. I want you to really sag, relax, and then come back down. Okay, so we're going to do that a series of 10 times. Same idea, the rule of 10. So we're going to do 10 while we're here. Matt's getting a little workout while he's getting paid. Isn't it great? He power lifts, and I'm going to give him a push-up here, so I think I'm not challenging Matt. But okay, so while Matt's doing this, I'm talking to him. I'm saying, hey, how you feeling? Does this hurt? Is it worse? Is it better? Where's the pain? How is the pain acting? We want to know how Matt's back acts, not how the textbook says. Right? Because we're going to learn what things are good for him, what things are bad, and then we're going to have a plan that we're going to develop. Okay, Matt, we'll pretend you got to 10. You probably got 8.5. Okay, so he's got pretty good range, and I'm going to pretend that Matt says this is better for him. The pain went from here and went out of his thigh into his hip. Good sign. You know what Matt tells me? That feels worse. And I go, too bad. Because the fact that the pain's moving up, that's typically a better sign, even though it feels worse here. As he does, let's do another set of 10. We don't have time-lapse photography. That's 1, 2, brrr. That was 10. Okay, come back down. Now he says, wow, the pain's no longer here. It's moving to the center. Woohoo! Tom's feeling happy. He's feeling good. He's got a happy patient. That's a very good sign. Listen, I've had patients that have told me that and came back the next day and were not very happy with me. But 99.9% of the time, 999, that's a good sign. Now, if I'm feeling really good, I still think he's a little tight. Let's pretend Matt just goes up to here, and he can't go any further. You know what? I feel relaxed. He's not osteoporotic. He's been very clear about his directions to me. He seems like he's pretty stable. I'm going to try and do some hands-on stretches with him. So maybe I'll do some press-ups. I'll bring the shirt up like this. We'll do some work on the lower lumbar segments. I can't fit behind there, so don't move the camera. And we're going to do some gentle stretches right over here, and that's going to help him. And all we're trying to do is help him with his stretching. We're trying to do certain stretches to his lower lumbar segments to help him, assist him with the stretch that he's doing on his own. So we will do hands-on the first treatment oftentimes, as long as we feel we're really sure that it's safe. And that's the key to this system, the Mckenzie system, is we're systematically giving more and more force. So let's try another 10, Matt. So we're going to do 10 more. He's going all the way up. He's locking out his elbows. And people vary in how far normal is. We treat some gymnasts and dancers here that they'll go up to almost a 90-degree. That's pretty good. I didn't realize maybe he danced when he was younger. He's almost very straight, and that's very good range of motion. They don't start feeling better until they go really high. So you might get, so that's why we take you through, and I'll do it a series of times until I'm sure that he's okay. All right, so let's have you stand up, Matt. So if you sit down for a second. So after I tell Matt, I'll say, Matt, you look great. You did the exercises. It seemed like there's been some improvements. I'll give him the rules as far as how the pain acts and how it moves, and I'll send him home. And I'll tell him, all you're going to do is this one stretch. Because sometimes people will go home and they'll get a Mckenzie exercise and they'll say, oh, well, I also stretch my hamstrings and I stretch my piriformis and I stretch everything else. And that can contradict the one. Also, so all I want you to do is this one movement, and then whatever else he's normally doing. Don't add anything new. But for stretching, I just want to do that one movement, or anything that really bothers you. If you do a clean and jerk or a squat and it really flares it up, I may tell you to stay away from that until we've watched him do it maybe, or checked his form, or we're really sure his symptoms are controlled. So we'll tell him that. Oftentimes the lower back conditions, we'll make sure he uses a lumbar roll, which we've talked about in other videos, to make sure he's using it right. When he's driving, sitting, he's a student, he's sitting a lot, unfortunately, probably reading extensively. Those are things. Also, the standing thing is I'll whatever movement it is, because sometimes it's actually going forward. My patients for lower back, they feel better flexing forward repeatedly. That's the movement that makes it better. So it's not that it's a Mckenzie exercise. We're trying to figure out which movement or position. And sometimes it's just a positional. I'll have him sit up on his elbows. Let me show that for them, Matt. So you're gonna lie on your stomach, and you're gonna prop up on your elbows like this. It's a way, and with this, I'll have him sit here for about 5 minutes and say, how you doing, Matt? And I said, wow, this stretch feels better. Sometimes people can relax better when they do positional. So it's position or movement is what we're trying to see makes him feel better. So that's sometimes. So whatever I give him, I'll give him a prediction of what to do. 10 times every 2 hours, depending on what they can do. If they can't, they can't. You can sit up, Matt. I'll say, oftentimes I like to try and do a walking program, especially he's been doing a lot of swimming, so the swimming, maybe even get 20 or 30 minutes of walking, as long as it doesn't make the condition worse. I don't want them to sit more than 30 minutes if they can. Get up, just move around. They don't have to stand up for 30 minutes, but they have to get out of that one position, so they're out of the seated position, especially if that's what they told me on the evaluation. Sitting kills me. I think we said Matt can only sit for 10 minutes. Want to make sure the sitting is a little more comfortable, and the use of the roll is supposed to kind of act like a brace for the back temporarily. I think it's good preventatively too, but especially for Matt, to him break the cycle, we want that spine to be in a more protective state and hopefully feel better. So that's prescription. We don't sit more than 30 minutes. We want them to do the one movement or position that we've told Matt to do, and told him not to experiment, get excited, do other things. But we're going to pick one movement for him to do, and we'd like to do a little bit of a walking program. And we'll follow up sometimes the next day if I really am not sure and I want to see them right the next day, see how they're doing. If I feel pretty good about it, I'll push it out 2 or 3 days. I typically know within 2 or 3 treatments if we can help them and how much we can help them. At 6 to 8 treatments, that's our average. It may go a little longer or a little less than that as far as that condition. But that's the Lumbar Mckenzie Evaluation, and our goal is to have people move better. It's a very active approach. We want to keep Matt swimming if he can swim, if he wants to power lift. If he does the quads and he's okay, let him do it. He may not be doing jumps with the quads, but if he does some good flats, I want him to be as active as he can, because the more he's active, he's going to be less depressed, he's going to be less angry about this, and I don't want him to be fearful. I think what people think with some of these back conditions is that people are very fragile. I think we don't give respect that if we have the right precautions, we can be as active as we can within reason. There's always freak things. You can always get a twist, someone wakes up with problems. Sometimes these things occur from sitting, let alone CrossFit or whatever else. So they can happen, but if people understand how their back acts, that's also important. So those questions I gave Matt early, he's starting to understand what bothers his back and what things he should be a little careful or be mindful of. I'll say, sometimes when people improve, they'll say, wow, I haven't had any back pain, but the other day I got a little tingling down my leg. It didn't last that long. I'll tell them, do the exercise a little bit more, and when that happens, try and turn that off. Try and do the stretch that seemed to help you initially. Take care of that in the early stage before it becomes really maddening, and all of a sudden we've got to shut down his swimming, everything, because everything is bothering initially. So those are some of the things just to consider. That's kind of how we do a physical therapy evaluation, at least here at Apex, for lower lumbar conditions. We also do it for neck conditions, also joint problems. But that's one of our approaches, and that is our approach, I should say. And then once people start feeling better, we start looking at his form when he's doing his let's say his powerlifting or lifting, maybe his swimming form, maybe you can work on that a little bit. And we start doing more of a general strengthening program before we send on his way. Make sure he's got good strength, good quality of movement, and we've kind of adjusted all the areas that he wants to get back to. And that's ultimately the goals, which we didn't talk about. What's your goal? I want to go back to quad. I want to go back to, I want to study for an hour, 2 hours, and not get up all the time. So we want to get those goals and find out what the patient wants. So I hope this helps you understand what a physical therapy evaluation is. You didn't see us doing any strength testing and such. That's part of the evaluation as well if we're concerned about weakness, especially neurological weakness, which means like a big nerve off the back. The sciatic nerve is really getting impinged to the point where it's creating weakness, and we're concerned. If we see that and we think it's getting worse, we'll send Matt away to some of his colleagues in the orthopedic realm or a general practitioner or someone they think is appropriate. If you have any questions or comments, please put them out there. We'd love to answer them. Big thing is try and seek help early. Just don't try and be passive about it. Try and be active in it, so you don't, stay away from things you really enjoy doing. Please share this with your friends if there's someone that's got a back issue. If you don't come to me, come to someone. Don't just let it go. Kind of take a proactive approach. One of the big things they found, don't get bed rest for 3 days. They said after 3 days of bed rest, your conditions get worse. So you want to keep moving as much as you can. Don't completely shut down. Those are some of the things. There's more that we actually talk about when you come here, and the evaluation's longer than what we showed. But I wanted to give you an overview and get a sense of what physical therapy was, especially if you haven't been exposed to it or haven't been exposed to the Mckenzie Evaluation. So anyway, have a great day, and look forward to a wonderful summer. All right, bye-bye.